Good evening, everyone, and welcome on behalf of the Dental Deans to our second webinar of the series. My name is Ian Mills. I'm the Dean of the Faculty of General Dental Practice, and it gives me great pleasure to welcome a fantastic panel this evening to discuss a topic which I'm sure for many of you will be of great interest. We're going to be discussing testing and vaccinations, which obviously is at the forefront of our mind at the present time. I'm joined this evening by Andrew Baldwin, a consultant oral and maxillofacial surgery at North Manchester General Hospital, who's also a member of the Council of the Royal College of Surgeons of Edinburgh. Onkar Denoya, who's the Senior Vice Dean of the Faculty of General Dental Practice. He's a practicing dentist, a practice owner in Newcastle. Matthew Garrett, who's Dean of the Faculty of Dental Surgery at the Royal College of Surgeons of England, who's also a consultant in restorative dentistry at the Eastman Dental Institute. Albert Lung, Professor Albert Lung, who's Dean of the Faculty of Dentistry at the Royal College of Surgeons of Ireland, who's a Professor of Dental Education at UCL and the Eastman Dental Institute. Kathy Lai, who's a consultant medical virologist in Belfast, and who's also a member of the SDCEP Rapid Aerosol Generating Procedure Rapid Review Group. And finally, Emma O'Keefe, who's a consultant in dental public health in Southeast Scotland and Fife. So welcome to the panel. Some great expertise, which I hope that we'll be able to take advantage of this evening. I'm certainly looking forward to them answering a number of questions. We've got the opportunity this evening to answer questions from our attendees, from our participants. So please, if there's any burning questions that you want to put to the panel, put them in the Q&A section on the right side of your screen. And if we don't pick up these questions through the panel discussion, hopefully we can have a rapid fire question and answer session towards the end. So we're going to kick off with a discussion around testing to start with, and this is a topic I'm going to throw out to Kathy and Emma to start with, and perhaps if I can ask Kathy first of all, just give us an overview, an idiot's guide for me as to what tests are available at the present time for COVID-19.
So I'll just give a very brief overview, Ian. So as everyone's aware of, the PCR test is the most sensitive and the test of choice that we would use to pick up symptomatic cases. And that's what is done in the Pillar 1 and Pillar 2 testing. So the new tests which have joined the market more recently are the lateral flow devices. And the benefits of these tests are that they are very much a point of care test. They can be done very quickly. So for the PCR tests, you're talking about a turnaround time of at least 24 hours. And in situations where you're waiting to, for example, perform surgery for someone and you're trying to restratify them, you really want a much more rapid assay. So these tests can be ideal for that reason. And more specifically to the actual sensitivities and specificities of the, I'm sorry, I'm getting a bit of feedback. The PCR assays are much more sensitive, and so there is a risk of the lateral flow devices missing out cases of patients who may be positive for SARS-CoV-2 as well. However, this seems to be being used as a positive in the rollout of these pilot tests in healthcare workers. So, and across England, there's been various hospitals and GP practices who have implemented the lateral flow device testing for healthcare workers. So these healthcare workers are given a test kit which contains something like 25 tests, which they can use to test themselves twice weekly. So the benefit is that you can do these tests more frequently It's done at home, and you can get a result in 20 minutes or half an hour, depending on the assay. And this would have the benefit of then stopping someone who does test positive but is asymptomatic from going into work and spreading it in the hospital setting. So that is one of the benefits. And there has been some controversy around the use of these assays, because when they were being validated, for example, in Liverpool, it was found that it very much depended on who was taking the sample. So you have that issue. If it was a sample taken by a healthcare worker, the sensitivity looked quite good, about 70 to 80%. But if it was performed by a layperson or just someone who had bought the test kit off the market and without any training, you could have a much lower sensitivity of only about 50%. So I think there are various issues surrounding the appropriate training before testing. So we also have the issue that there is a high rate of false positive results from the lateral flow assay. So at the moment, all the positive lateral flow tests need to be confirmed using real-time PCR test. So potentially, if you're implementing this device to screen in the dental practice, you may need to have a number of staff isolate until a PCR result is available then. And this will become more of an issue as the prevalence of COVID goes down. You will get more false positive results. So it's very important to have the secondary test with the real-time PCR to confirm this result as well. So this is just a very quick overview. I don't know if I've probably missed out a few things, but feel free to jump in, Emma, or any of the other panelists, or if there's any questions. So I think that the test that is being used at the moment around the UK and the NHS is the Innova Test, simply because they were the first off the mark and they were able to provide the number of kits that we require to roll out the pilot testing. It's not necessarily to say that it's the best test, and I think there are better point of care tests coming out now, which will have a better profile, so a higher sensitivity and a higher specificity as well.
Okay.
So hopefully,
Thanks.
I mean.
Thanks, Kathy. That's good. If I could maybe come over to you, Emma, and just comment on your experience of the different testing regimes and how they have been implemented, perhaps in Scotland.
Brilliant, thanks, Ian. So I'm very much speaking from a Scottish perspective, so other colleagues do chip in. So in Scotland, we're just about to roll out the lateral flow tests in the primary care setting. So it's exciting, and as our national procurement teams were talking about rolling it out from the dental public health perspective, we were very much wanting to ensure we had the clear message going out about what do they mean. And if we get a positive test, what's the pathway that we need to put in place to ensure quick isolation of both the individual and the households that they're with, and following the government guidance, and then to quickly get a PCR test to confirm whether that test is positive or not. And the other thing that is really helpful now, I think, is as soon as that positive lateral flow test gets uploaded onto our case management system, which is our national system for reporting positive cases, we start immediately with a contact tracing. So I think the asymptomatic testing is really exciting. I think it will help practice setting and other secondary care settings as well, where our colleagues have already been doing it. But from the dental public health perspective, we're very much still seeing, infection prevention control is key, PPE, face masks, physical distancing, particularly in the non-clinical areas, the staff rooms, changing rooms, etc. being very mindful of environmental cleaning, symptom vigilance as well. So really getting the clear messages out to staff: if you've got any symptoms, please don't come to work, and good hand hygiene and respiratory hygiene. Ian, will I just quickly see the PCR testing? I know colleagues south of the border might mention it as well, but we're just about to do asymptomatic PCR testing once a week in a practice setting and our community dental services equivalent, which we call the public dental service as well. And that will be as well as lateral flow testing if our staff want to do that. So lots of possibilities. So thanks, Ian.
Yeah, thanks, Emma. That's really useful. And I'm going to come to Onkar in a minute just to get your experience in general practice. But Andrew, I know you'll be a bit further down the line than we are in primary care in terms of point of care testing and also testing of staff. And I was wondering if you could maybe just share your experience and your thoughts on that.
Yeah, certainly within secondary care, we're trying to encourage everyone to take up the lateral flow test and be tested twice a week. As Kathy's already mentioned, the lateral flow tests are more accurate when the viral load is higher, so they're better suited to spotting spreaders rather than identifying everyone who is infected. The advantage, and they don't always pick, they pick up for 1 to 3 days prior to the onset of symptoms and about 5 days afterwards, so which is down to when the viral load is higher. There are times when someone may have obviously the virus, but the lateral flow test won't pick it up. But that's the basis for us for the regular testing, because if you're testing twice weekly, hopefully you're going to hit it as it's on the way up and actually spot those people before they then become ill and get them as soon as you can. So although obviously this can't be enforced, there is a lot of encouragement for people to do the testing. There's a link that you have to report and log each test that you've done, so that the trusts are aware of who is being tested, who's testing, and what those results are. And that obviously that also gives you a link in if you do test positive as to what you do next as regards getting a PCR test and then potentially isolating.
Thanks, Andrew. And Onkar, if I can maybe ask you to comment about your experience of introducing this to general dental practice.
Yeah, sure, Ian. I mean, I think in general practice, from what I've having spoken to colleagues, there's been sort of a mixed uptake of using lateral flow in general practice. Some practices have started and using them quite regularly. Some practices have been a bit reluctant. I think one of the issues, as Kathy has said, is the lack of accuracy. The fact that up to 50% inaccuracy, and that again, the important thing really for general practice is that just because you have the test and it's negative, you shouldn't really relax any protocols, any precautions, because you don't know whether you're picking up people who actually may be carrying the virus or not. So one of the downsides, I suppose, from general practice point of view, is that people may become a bit more complacent, which will not be helpful. But I suppose, if you are picking up even 50 to 60% of people that you wouldn't normally, that would help control the spread. But I suppose in general practice, the protocols that we have in are pretty robust, and at the moment I don't know of a lot of spread in general practices. So as I say, it's a mixed bag. There are some practices who've adopted it and are running with it completely. Some are starting slowly, but these are sort of the concerns in general practice.
Thanks, Onkar. And I think I'm right in saying that it's not a regulatory requirement within the NHS to do this, but it is to report. And I get the sense that there's a growing realisation of the value of lateral flow testing as long as it's done on a regular basis. And the points I think have been made about understanding that you need rapid access to PCR to confirm a positive test, and also that we don't allow our standards to slip. And I guess that's the same across all secondary care and primary care. And I've had a question just come in from the audience as to what does the lateral flow test involve. So I assume that's someone that hasn't subjected themselves to a test. And I don't know, Matthew, I know that you have. But I'm going to come to you too.
Well, I have had a lateral flow test, but actually, in the hospital that I work in, we are actually we are encouraging all asymptomatic staff to have a PCR test on a weekly basis. The reason that I had a lateral flow test was because a little bit of interest as to what actually happens in the testing process. And one of my patients happened to be a practice nurse, so she brought a kit in and she did it before her treatment, and then on me she did it before her treatment, and then at the end of her treatment the result was ready. I can't exactly tell you exactly what happens in terms of the reactions. We can ask Kathy perhaps about that. But one of the things that I was interested in, and Kathy mentioned this, was about about training for lateral flow tests. So, we have mentioned that when a sort of general public did a test, the result was slightly less reliable than when a professional did it. So I was quite relieved that I actually had a practice nurse to do mine. But in terms of training for general practitioners, what sort of resources, Kathy, I suppose the question that I would have, would be available for them? And perhaps you could also describe the test, but I said I can't do that, I'm afraid.
So I think the test is the antigen on a strip test. So it's similar to a pregnancy test, the Innova one at least. So you have a control which checks that the test is actually working, which is a control strip, and then you have the strip which is coated with the antigens from the virus, which if it's positive will mean that it'll be positive, and then then you have a negative control as well. So the actual test, I think there's quite a lot of instructional videos now posted by various trusts that you can see. You might have some experience of it, Ankur. But yes, the swab itself is not as traumatic as the nasopharyngeal swabs that are being taken for some of the other tests. And I think the training aspect of it is going to be
I'm a little bit of a wuss.
Still traumatic enough. So it can be traumatic enough then. But yeah, so there are other tests being developed or already CE marked actually, which use saliva instead, which is thought to be less traumatic. So instead of having to do a nasopharyngeal swab and then a throat swab, you can actually use a swab which it just picks up the saliva, almost like a sponge. But the actual test, so I take it you had the practice nurse doing it, so you might not have had to put the swab into the extraction buffer, and it's quite particular in that you have to swirl it around 5 times and then squeeze out of the swab as you take the swab out of the container of the little vial. But it does look relatively straightforward. If you get a chance, I would recommend watching some of the instructional videos that are available from various sites. And then you do have to incubate it for, so after you add the drops onto the strip, you have to incubate it for half an hour. And I think you can't really go over the half an hour incubation period or you might get a false positive result. So it's quite important to set a timer. And that's that would be I think that would be the Innova test, which is being rolled out currently. But there are other point of care tests, some of which are maybe more for use at practice. So in the emergency departments here, for example, we've got the kit called Lumira DX, which has a much higher sensitivity, but it is more involved. So you can't really do it as a point of care test at home. You still need a machine that you put the chip or the the sample onto a chip onto the machine to read. So I think, sorry, I've gone off on a bit of a tangent there, sorry, Matthew, but yeah, so that's the premise of the lateral flow tests, and the training that is involved is very important. And I think most of the trusts who are rolling out have had to issue these videos as guides for patients or, well, healthcare workers to use.
Could I ask another question, Chair, please? How are these cheap tests relatively compared to PCR? What's the price difference between one and the other?
I think it's about £4 for the lateral flow test, the baseline. I don't know how much the PCR test cost is, but yeah.
I'd like to point out that was from the English Dean and not the Scottish Dean that was asking the question about that. Onkar, I saw that you were going to come in. I don't know whether, was that to...
It's just basically on Matthew's point. I mean, there isn't really any official source of education or training for general practice, but there are leaflets available which you can download from the NHS, which it's a pretty simple test to do. I think, as I say, the important factor is how vigorous you are in collecting your sample, and you know that's one of the other fears I have, that obviously these tests will be carried out by our staff at home, you know, possibly, you know, on themselves or by their family members. How accurate or you know, how vigorous they are going to be in collecting their sample will determine how accurate the results are, and therefore it will influence how much or what effect it has. So
thank you, Albert.
Yeah, I think that despite the problems and the limitations we have with the lateral flow test, one advantage has been mentioned there is that 1 in 3 who are suffering from COVID, the carrier of COVID, is asymptomatic. So there's a much better chance, even with less sensitivity on the test there, to be able to pick up those who shed a lot of viral load to prevent them from spreading it elsewhere. I think that's a very good thing to have, almost as a screener, so that other PCR tests can take place as a targeted approach. And I think that is important, because in primary care, in other situations there, you can only trust what the patient tells you, as much as screening, as much as leaflets, as much as questionnaire. They may not know what they don't know, and you might inadvertently be spreading the virus around. And because you still have vulnerable colleagues, patients, and others around, vaccination is not quite there as yet, even for all the vulnerable groups there. So the less likelihood of someone inadvertently spreading the virus, the better it is as far as the public health itself is concerned, I think. Coming back to the point of difficulties of getting samples, they are all pretty nasty way of getting samples. It's not a very natural way in which how the samples can be obtained. It's almost there that, can you get to the back of your nose, your throat, and all the time? The answer is very, very difficult. They are training, I think, YouTube videos and things, but if you are to do it yourself, if you ask yourself to pinch yourself there, you're not going to pinch it very hard, because you know that it's not going to be comfortable. So it's almost self-defeating the purpose. But still then, you're still going to pick up some which would allow the control of the virus spread to be effective in maybe in a wider primary care situation where you have a more rapid result, I think.
Thank you, Albert. Andrew?
Yeah, just to come in on that, the Innova one, which is what we're using, is the good thing is that you only have to sample up the nose. You don't have to make yourself gag or retch. So that's one slight advantage. So you've got a 50% reduction on the unpleasantness of it. And again, I think it's just going back to what I think Emma said. I think we've got to realise that the lateral flow tests are just part of the solution. You know, it's one way of trying to minimise spread, but you know, we still need to go back to the distancing, the PPE. You know, it's a jigsaw puzzle, and there's lots of pieces to go into that to make it all work. We've been talking about testing the staff. What has just recently been introduced, certainly in our organisation, is that we're now testing the patients at point of entry into emergency department with lateral flow tests. Now, clearly, you're not going to pick up everyone, as we've already said, but at least if they're then going to potentially be admitted and you do pick up positives, you at least are going to put them into the right area of the hospital so that they don't become spreaders within hospital. And I suppose maybe one thing we need to be thinking at is that something that we introduce into, dental practice, not just for the staff, but also the patients as they arrive, because clearly they could be the spreaders as well as not just the staff. So, and I know there's a cost implication to everything, but maybe that's sort of a discussion down the line.
Andrew, I think that's an excellent point, and one that I may, if you'll forgive me, throw towards Emma. That obviously there are challenges around the sensitivity and specificity of the lateral flow test, and also there's some confusion at the present time in terms of the risk pathways that Public Health England had promoted. So would a lateral flow test on a patient mean that they were then eligible for the low risk pathway? Would that be viewed as a definitive test, a lateral flow test?
So, Ian, I would say at the moment, based on our SDCEP recovery of the dental practice and also the national standard operating procedures, the green pathway at the moment is PCR testing. And I think as lateral flow comes in, we had a bit of a discussion at the tail end of last week, is how
I think I'm losing you a bit, Emma. I don't know whether everyone else.
Well, what do we have to do to change the pathways? And it's that. So I think it's a discussion that's required at the moment. We're looking at, if you've had a recent result from a PCR, then you can go into the green pathway. In terms of PPE and what I would expect the dental settings to do, I'd still very much want them to be following enhanced cleaning and infection prevention control and PPE. And I think if we did introduce it, it's a time factor, isn't it? So I'm very aware that our dental teams that go into care homes, if they haven't done their own lateral flow test, then they have the lateral flow test done by the care home team. They're then told to go and sit in their cars for half an hour for the results to come back. So it could be a good way forward in terms of bringing patients in and patient flow. But I think there's quite a lot of things we need to iron out beforehand. But that's just my opinion.
So thank you, Emma. So I think to summarise, we're saying that there is potential moving forward to use lateral flow as point of care tests for patients within dental practice, but we shouldn't view a lateral flow test as an entry point to the green pathway or the low risk pathway at the present time. And I'm just going to jump across to Andrew quick. Andrew, so when this has been used at the hospital, is that within a 72-hour period and they have to self-isolate during that, or is that that is being done on admission?
Yeah, so any elective patients are getting your routine PCR test. Okay, so that's the elective pathway. What I was referring to about the lateral flow test was anyone arriving through the A&E department, so that they can either be, clearly they can't be allocated to the green pathway purely based on the lateral flow test, as Emma's just said. But for those that it picks up some positive reading, pending the PCR to confirm whether it's positive or not, they would obviously be isolated differently because they would be a sort of a higher risk than someone who had a lateral flow test that was negative, but they would still both get a PCR, but clearly you'd have to have a greater degree of suspicion for someone who tested positive with the lateral flow test than somebody who didn't.
Okay, well, thank you. We've got a few questions coming in on testing, so I think I'm conscious of time. Before we move on to vaccination and then pick up some other questions, I'll just fire a few questions out there. And one from Derek Richards. I don't know whether it's the Derek Richards they're from SDSEP or not, but the question which I think Kathy might be asked to pick up is, are all asymptomatic patients shedders of virus?
Thanks, Ian. So that's a very interesting question. It's how much of a risk are these asymptomatic patients? And I think more recent studies and more recent papers have shown that these patients can have similar viral loads to patients who are actually symptomatic. So there is a real risk, and especially in with the newer variant, which is thought to be the new variant, which is thought to be more transmissible because of the higher viral load that patients infected with it carry, that these patients can go on to be super spreaders. So there doesn't seem to be a difference in that asymptomatic patients have lower viral loads. They have similar, they do carry similar viral loads, and if not higher. So this test, the lateral flow devices in this situation are particularly useful if you're screening asymptomatic patients who, as it picks up a higher viral load, you will be more likely to pick these patients up who can go on to transmit. So I think this is a case of using this test quite appropriately in the setting to try and pick out these asymptomatic spreaders.
Okay. No, thank you, Kathy.
That kind of answers the question.
Yeah, no, thank you. Yeah. I'm going to segue across into vaccination by using one of the questions that's come in. But do you have an indication of positive test numbers in staff who have had one vaccine dose? So I guess that's asking, whether the vaccination or specifically the first dose of the vaccine is likely to reduce your infectivity. So I don't know whether anyone wants to take that, or whether we go back to Albert, and then we'll ask Kathy in a bit.
I think no matter which vaccine that you get, whether it is Pfizer one with the AstraZeneca Oxford one or the other ones there, it takes about 14 days or so for the initial build-up of the CD4 plus CD8 plus cells to develop some sort of immunity. So in that intervening period, if you are to catch the coronavirus as such that you will still test positive big time, makes very, very little difference. You will still depend on your, I think, the interleukin 1B, 6, 8, and other pathways to defend yourself, which is not as effective. So you're going still to shed lots of viral load. So in those patients there, it will be very difficult to look at whether they're actually shedding or not. As to the effectiveness of any viral loads itself there, that you probably might have to wait until after this period of time when reasonably the CD4, CD8s would have taken effect on that before you measure them to see whether there's any effect on the vaccine or not. Otherwise, you're still measuring the baseline population with very little difference in the two measures, I thought.
And Kathy, is there anything you'd like to add to that, or any of the other panelists?
So I think probably just to reassure everyone, this is being monitored. So all the staff or everyone who has been vaccinated recently who test positive for COVID, their samples are being picked up, and if they do test positive, will be sequenced as well, just to monitor for vaccine escape variants as well. So that's being kept an eye on. And I think, as you said, Albert, if you test positive within 14 days of receiving your first dose, it's not necessarily a vaccine failure, but it does take a while for your immune system to mount a response. So I think it does come back to what Emma was saying earlier in Encore as well, that you do have to really be vigilant and keep all your PPE, physical distancing, all the other measures that we have been using up to date, up to scratch, even if you have been vaccinated, and even with the persistent testing. So I think that's the main sort of take-home message from today.
Okay, great. I mean, clearly the vaccination program in the UK has been one of great success, and you know, we ought to congratulate our many colleagues working within the NHS and the government for delivering or passing the 15 million target. But clearly, there's quite a long way to go, and I guess I'd ask the panel that you know, is vaccination, is that our way out of this pandemic? Are they as optimistic as many of the population are that there's light at the end of the tunnel? So perhaps if I can turn to our consultant in dental public health first, Emma.
Thanks, Ian. But everyone chip in. I mean, I think it's part of our armament, isn't it, the vaccination programme? And as you said, it is very exciting. And let's hope that we continue getting the uptake. I think we have to be very mindful that we are working with the members of the public to come forward, and our healthcare workers as well. So I think what was on the news maybe in Scotland is 1/3 of our care workers working with really vulnerable people haven't come forward for uptake. So I think it is definitely a key part of getting out of the pandemic, but it's not as easily said as done and said. And it is very much about what's the critical vaccination level in order to get the herd immunity. And I think there's still a lot of work to be done in terms of how effective the vaccine is, the first dose and then the second dose, and how long will the vaccination help people. So I don't want to be a party pooper, but I think it is exciting, but let's carry on with all the other measures as well that's in place.
Andrew.
Yeah, I mean, Emma, you might want to sort of, I don't know whether you can put any specific figures to this, but I know I read something at the weekend that they were saying that maybe you need up to about 75% herd immunity, 75 to 80% protected from infection to get the herd immunity. That might be a bit high, I don't know, but the concern is that obviously, as you mentioned, certain sort of maybe minority groups, people who are anti-vax, and particularly maybe the younger generation who, you know, may not come forward because they don't think it's particularly affecting them, whether we'd actually get to that critical level, the percentage that is quoted, because it seemed from the figures that I read that was a particularly high percentage to have to reach to get this herd immunity that we're all after.
Yeah.
I thought that you had a hand up to come in.
Yeah, sure. I mean, again, I think it's a multifactorial thing. I mean, you know, vaccine is just sort of one part in helping us get out of this pandemic. But I think one thing we must remember, that it's not just, you know, us. It's a global thing, really. We've got to approach this from a global point of view. You know, getting vaccination up to a maximum in this country alone, in our country, isn't going to help if there are variants being produced in other countries, which we then have to protect from. So I think it's got to be a global thing. But yes, I'm definitely optimistic. I think, you know, the vaccine is definitely helping, cheering me up a bit.
I'm glad to hear that. Right, Albert.
Yeah, I'm just going to say, agree with what Andrew, Emma, and Onka have been saying, that I think looking at, from my own perspective, being the Dean of the Royal College of Surgeons in Ireland, Republic of Ireland, there is a population of 4.96 million in Southern Ireland and 1.7 in Northern Ireland. As far as the Republic of Ireland is concerned, as of yesterday's date, only 265,237 doses has been administered, and 89,900 have had both doses, i.e. it only reached 2% of the population. 98% have not had a chance of a vaccine. So it's very, very far away from what herd immunity would do and would be. And the doses are still very, very high. And they still didn't even have the use of the lateral flow tests as a matter of routine as such. So even within the European Union or others and our neighbors, there is a big difference in the amount of what they actually achieve. So I think that the other method of precautions, infection prevention and controls and others, to very high standard, minimizing aerosol generating procedure for dentistry and the likes of it, plays a vitally important part for a very, very long time to come in respect of COVID, in respect of the new variants and others that invariably we will see over a very, very long period of time. The UK has just been very, very lucky, very fortunate that we have at about 25% of the populations there, or 20% of the populations having immunizations as opposed to others.
Thank you. It's always fantastic, Albert, to have your input and your knowledge and your expertise. But it also gives us a sense of perspective, I think, sometimes when we beat ourselves up in the UK about how badly we're doing. And it's useful sometimes, whether it's around education or immunisation, where we get an appreciation of what's going on in some other countries. Matthew, can I bring you in?
Yeah, it's just a comment to say that I'm equally optimistic along with Onka, and actually I suspect that the challenges will come when those invited for their second dose of vaccine are then to be vaccinated alongside those in groups maybe 5 and 6, that haven't received their first vaccine. So I think there is quite a long way to go, but I'm very encouraged by the figures today, which you may have seen, where we've got a drop of 4,500 patients in hospital in England. So we've now got 16,500 patients in hospital, which is 4,500 less than we had last week and 5,000 less than we had the week before. So we're not out of the woods, but the things seem to be turning the corner, which is encouraging, I think.
Sorry, okay. Ian, just to add to that, Matthew, I mean, it's also encouraging that, the single dose that most people have had now is reducing the seriousness of the disease. So hospitalization has come down and deaths have reduced. So, that's another step in the right direction.
And I think, as we're very fortunate to have leaders of the dental profession here this evening and representatives from all the dental faculties of the Royal Colleges, and I think there's a responsibility on us to get out and shout loudly that the importance of vaccination across the profession, our family, friends, colleagues, and our patients when it is available to do so. So, I think perhaps there is a piece of work that we can do to engage with any of the more resistant corners within our profession or beyond. And leading on from that, I'm interested if any of you have had experience of staff or colleagues who are concerned or anxious about having the vaccine and what their anxieties are, and perhaps we can touch on that this evening. So let's start. Yeah.
Yeah, I mean, we certainly have had amongst one or two of the young nurses in my practice were a bit anxious at first about receiving the vaccine, but having sort of spoken to them, I think their fears really were, again, listening to the anti-vax propaganda that's out there about young women and fertility and things like that, and once we discussed it with them, they were quite fine, reassured, and went on to have the vaccine. But I think you're right. I mean, there's a Panorama program last night, Ian, which highlighted the disinformation that's out there, and we do need to actually promote the vaccine in our profession.
Kathy, I think
just to add to that, Ankur, I think, thanks, Ian. It was just to add to that. I think with the numbers that have been vaccinated to date, there's been over 4 or 5 million people vaccinated to date worldwide with the Moderna and the Pfizer vaccines. And there's been no or very little, less than 1% of severe adverse events occurring. So I think that's a lot of data to support this view that it is absolutely a safe vaccine, and we need to definitely push this message out to healthcare workers, especially to lead by example, really, and to get everyone on board to get vaccinated. So I think do feel for Emma in public health, you've got your work cut out to try and encourage people and get that message out there to try and persuade these people who are a bit vaccine hesitant to reassure them that it is an absolutely safe vaccine and it is having a great impact, as you can see with the numbers Matthew mentioned, with the numbers of hospitalizations and severe disease going down, that it is definitely a message that we need to get across.
Thanks, Kathy. And there are a number of excellent resources and support, whether that's through Public Health England or the Royal College of Obstetrics and Gynecology and the Royal College of Midwives. They issued a statement very recently, which if any of your staff have concerns about around conception or during pregnancy or breastfeeding, there are some very good resources online there. Albert.
Yeah, I just think that as a matter of fact for the vaccines there, the manufacturing of the vaccines there does not use a lot of the potential allergens, which used to give a lot of the problems like eggs and others. The use of preservatives that are no longer in existence, so much so that they have to be stored under these sort of temperature for the mRNA type of vaccine to be effective. That a lot of the side effects we would normally have been associated with the other vaccines there are not there anymore. And even the vector type of vaccine, like the AstraZeneca Oxford vaccines itself there, has largely eliminated those through the work in the last few years as to, I wouldn't say it's perfected vaccine, but minimize the amount of problem and side effect that we have. So that in scientific terms there, we should be a lot more confident about this than we were. The other thing, though, people would need to notice is that the approval for the European Medicine Agency as well, MHRA, there is an emergency approval at the moment because we cannot afford to wait 3 or 5 years before we come and have the vaccine. So that's the reason why there isn't such a strong, solid evidence of scientific data behind it. But it doesn't mean that it doesn't work there. And it is an extraordinary situation. That's why the community, the whole wide world scientific community, brings it forward with the vaccine. But with the numbers that is around, the number of vaccines that has been given, and the side effects and the effect that you have, this is the biggest trial that you will have in terms of side effect without having to report it every single day. So colleagues, I think, should feel relieved that there is such a facility for us to be able to train our CD4, CD8 cells rather than to have to let nature take its own course, as it was like in the Spanish flu situation 100 years ago, when 1/3 of the population of the world was affected and there were, what, 150 million who died? We don't want to see the same thing happening again.
Yeah. Thank you, Albert. A number of questions are coming in through the Q&A, and one from Paul Cooney. Will vaccination become mandatory for clinical staff? Just interested in your thoughts, and perhaps any comments about how we can encourage any resistant or recalcitrant staff who are unwilling or anxious about getting the vaccine. So if you don't jump in, I'm going to pick on Emma again as a dental public health consultant. Emma. I think, have you frozen? Well, so does anyone else have a view on whether it will become mandatory? Albert. Yeah.
I have a view there again. I think, sorry. I think in terms of civil liberties, you can't force people to have a vaccine. It has to be through persuasions. It's not that you can, but it's in their interest to do so. You just have to be very, very persuasive as possible. But unfortunately, about 30% of our population is thinking that, oh, somebody else is going to give it a go, so we have cheap herd immunity without me having to get the vaccine. Unfortunately, that's the situation that we are in, the dilemma, chicken and egg situations. It's never going to be solved, but we can only try our very, very best to do so.
And Emma, have you got a view on that?
Yes, I think we've got to be very mindful of the Public Health Act around the control of diseases. So we can't make it mandatory, but I think it's how do we encourage, and who are the best people to encourage those that may be hesitant. And as you said, there's really good resources. I'm also mindful that some of our roles, very much do need certain vaccinations, and there is a contract obligation to have them done. So I think I'm no medical legal expert, but I think there's discussions that are taking place there. I think right now, let's just try and get that positive message out there and encouraging as well.
Okay, I'm conscious of Matthew. Was that a hand up?
Yeah, just to be, I guess, to use a little shock tactics in many ways. In that I have been volunteering as part of the family liaison service for patients in our local ITU, and I think just listening to the stories of some of these individuals whose loved ones were completely fit and well, and now in this really serious situation is just completely eye-opening for me anyway. And I think that would be for me the biggest encouragement for colleagues to get vaccinated, because this is real and it's affecting everyone, young people, not just the elderly, and there are some really sad stories with our families in ITU, and I think that for me really hit home the importance of really being vigilant and vaccination.
Thank you, Matthew. And I think sometimes we can feel quite remote from that. That's what we see on the television, particularly when you're based in North Devon, like I am, and we have a prevalence rate of 16 per 100,000 at the present time. So it's almost like it's happening elsewhere. So I think that's a really good point you make. We are getting a little bit tight for time, so I'm going to go to our rapid quick fire answer session. We'll rip through some of the questions here. Well, one that came in earlier was how long does immunity last? And I know that might be how long's a bit of strain, and there might be many factors, but Kathy or anyone else like to answer that in a couple of sentences?
Sure, Ian. I think the short answer is nobody knows. This for post-vaccine. There have been cases of reinfection now reported worldwide. So, and as you know, coronaviruses do cause a common cold. So you can be reinfected with a different variant. You can be reinfected with a different strain. But the short answer is nobody knows. But at the moment, currently, as we're sitting with the vaccine studies and the monitoring going on, it looks to be quite effective at preventing reinfections, but it's something we have to keep our eye on.
Okay, so no room for complacency. But yeah, so another question that's come in from Helen Milroy. Hi, Helen. If someone who has been vaccinated and subsequently tests positive, which we touched on earlier, would they have a similar viral load as an asymptomatic person, or would their viral load, maybe not asymptomatic? So I think it's the impact of the vaccine on the viral load if someone becomes infected. A view on that? Albert, you're nodding.
I think that it will be lower, because if you have effective immunization, the CD4+, CD8+, the basal cell, B cells, and other macrophages counts specific to these antigens will be much higher. So by definition, you would have a lower count. It doesn't mean that you don't get infected, but you may be less likely to be a super spreader at that rate, and more likely that your immune system is going to conquer and reduce the effect of it, I would say.
Okay, fine. And
just to add to that, Albert, so there's no, it's really difficult to study, but the vaccine studies have looked at that and looks promising. It looks like that it has had actually an impact on reducing transmission. So that's a short addition to it.
Brilliant, thanks, Kathy. I'm going to go to Andrew with this one. So there's been a lot of controversy around the second dose and pushing the interval beyond what had been recommended. Andrew, what are your thoughts around that? And should we be concerned that there is a longer interval?
So obviously, I think initially, universally, when it was extended, people had alarm bells ringing, but you can understand the rationale for doing it. I think as time's gone on, those who've received the Oxford AstraZeneca vaccine, I think there is data that is fairly supportive of that manoeuvre. However, having received the Pfizer dose myself, the vaccine myself, as yet I haven't seen any hard evidence or data that supports this change in tactic. And obviously Pfizer themselves had said up to 4 weeks. The World Health Organization came out and said that they didn't necessarily support that. So I think those who've got the Astra, so in a nutshell, I think those who've got the Astra dose, I think there's sort of evidence that should be okay. For the Pfizer one, I'm not too sure, but maybe Kathy can update me if she's got more information. So that's as much as I know.
Yeah.
Thanks, Andrew.
Andrew, just to add to Andrew, I think I did read somewhere recently, Andrew, that the studies from, or the feedback from Israel is showing that the single dose in Pfizer is effective. So
okay,
but I can't quote the study though.
I feel a bit guilty always.
Yeah, so I think, sorry, just come back to that one. I think the Israel studies showed that the first dose with Pfizer, I wrote it down at the weekend. I think 52% after the first dose protection, but of course they quoted a 95 or 97% efficacy with the 2 doses at the 3 to 4 week window. As yet, I don't know what that efficacy is with a 12-week window, but maybe you've read something that's more recent. I don't know.
Yeah, sorry.
I'm just I'm conscious of, I keep going to Emma or Kathy for all my different questions. But Emma, there's a question that's come in saying, do we have any data regarding the success or the penetration of the vaccination program for dentists, dental care professionals at the present time? I don't know, either within Scotland or within the UK. And is this being monitored?
Yeah, so this was a question that we were asked by Scottish Government about how can we extract that data out of our Vax app, and at the moment we can't do it. So that's in Scotland. I don't know across the rest of the UK. So at the moment we can't do that unless we write out to every single dental practice and every dental setting and ask them to come forward with that information, I'm afraid.
Okay, and just we're running out of time. The last couple of questions, one which has come in on the Q&A, and also we had submitted before, was around the role of the dental team in delivering the vaccination programme. And I think this is quite variable, not just across the countries, but also regionally. And someone has asked, so I'd be interested just if anyone's going to comment on that, and also to answer a specific question. As an overseas qualified dentist with no GDC registration, but with the MJDF under my belt, I'd be happy to be involved in vaccination. Is this something I could put my name forward for? So I don't know if there's any comment about the involvement of the dental team in the vaccination programme, and then secondly, whether you need to be on the GDC register to be involved in the vaccination programme. Don't all shout at once.
Well, I dive in here quickly, Ian. So in Scotland, we've very much been promoting it with dentists being vaccinated and working under the national protocol, and also our dental hygiene therapists working under patient group directives. Some dental nurses are involved, but they're very much just doing the administration of the vaccine, so working under the national protocol, but with other people doing the consent aspect of that. But I know that there is variation across the 4 nations, and I think it has been easier to get involved south of the border. So I'll hand over.
Okay.
In our region, there was talk of the foundation dentists being deployed to give vaccinations, but I don't know whether that's actually been developed. But as Matthew says, I think the need for more vaccinators will occur when we start to give the second dose, as well as, you know, including all the other groups. So I think there probably will be a need for deployment from dentists.
Okay. So I think we're sort of running out of time, and what I'm going to ask is, just before we go to the final question, I'll maybe just ask you just to sum up, if I just go around, just to Albert first, just to sum up your thoughts around testing and vaccination from this evening.
I think that we need to have some sort of air of optimism that something is happening, that the world community, scientific community, is doing their very, very best, and vaccines and others in combinations are going to slowly help us out. From a global perspective, it will take a very, very long time. We're just very, very lucky being in the UK and Ireland that we are relatively advanced in doing that. But we mustn't count our chickens as yet, because there's still a long, long way to go, and we all have to take care of ourselves and really work very, very well with each other.
Thanks, Albert. And Kathy?
Yeah, so it has been a very tumultuous year. We've come a long, long way. Nobody could have foreseen that we would have had all these test platforms available at the beginning of last year, or even a vaccine. So that has such a high efficacy. So I think we've come a long way. The scientific community has really pulled through, and we've still got a way to go, but it is all very hopeful and it's looking very positive. So I think we should end on that high note, but to be aware we still need to keep all these precautions in place until we actually get to eradicating COVID. So.
Sure. And Andrew?
Yes, I'd agree. We are on the path to recovery. It might not be quite as rapid a path as we all would have liked, but I think we're getting there. And the testing is just one part of the jigsaw puzzle that I mentioned at the beginning to get us there, along with vaccination, along with distancing, along with PPE.
Thank you, Andrew. And Emma?
Yeah, I'll echo what everyone else has said, but I think it's been a phenomenal team effort, and just hats off to everyone, and I'm particularly mindful of people's health and well-being, because I think it has been really challenging in situations, and as Matthew said, you know, seeing powerful stories in the hospital setting, it just makes me feel, you know, let's be mindful and supportive of our dental professional, dental teams out there. And when there are outbreaks in dental settings, then how can we work with them rather than the blame culture? So hats off to everyone. And as I say to my team the whole time, every day is a learning day, but we're all in it together.
Oh, thank you, Emma. Yeah, and Matthew?
Yeah, absolutely. So I think I've learned a lot tonight. I said to Ian earlier, I'm no vaccine expert and I'm no testing expert, but I feel slightly, much more well informed. But what I would say is, as Emma has said, and I echo that, you know, all the dental team has worked extraordinarily hard, and you know, we've got to look after ourselves. And I think I speak on behalf of all the dental deans here and everyone on the panel to say, you know, do look after yourself. The faculties are here to support and help, and you know, we've all got confidential support and advice lines for members and fellows. And I suppose that if there's anything that we should be doing, then just let us know what we can do to help and support.
Yeah, thank you, Matthew. Yeah, well said. And Onker, finally.
Again, just to echo what everybody else has said, and yes, I think with the vaccination and the testing, you know, there is light at the end of the tunnel. I don't know how long the tunnel is, but definitely I have seen a change in my patients. They are actually optimistic. So I think it's good.
Yeah. Well, thank you very much indeed, and it gives me a great pleasure to thank all the panelists this evening. Matthew said earlier that he feels much better informed. I certainly do as well, and I'm glad I was the person asking the questions and not answering them this evening. My cunning plan. But I'd also like to thank the participants for joining us this evening. Any of the questions that we haven't got round to answering, we will endeavour to do so offline. There will be a recording of the webinar for anyone else who wants to go back over what was said. Emma mentioned earlier that the importance of health and well-being, and I'm delighted to say that that there will be one of our next webinars. I think it's not. I think the one after the next. So I believe that's on the 20th of April. Is looking at health and well-being, and I can't remember. That's either being hosted by Glasgow or Edinburgh. I can't remember which one, but the details will be coming out shortly. And I'm just grateful to you all for joining us this evening. I wish you a safe return back to work over the coming months and years, and we hope to see you soon at the next webinar. So thank you very much, everyone.
Okay.
Thanks.